Hi, everyone. Welcome to the 2023 PI Conference. My name is McKenna Kresley, and I will be your moderator for today's session, Antibiotic Use and Antimicrobial Resistance. I am excited to welcome Dr. Freeman, who will be presenting this topic. There will be time for questions at the end of the presentation. Please submit any questions you have to the presenter in the Q&A section of the platform. Dr. Alexandra Freeman is a pediatric infectious diseases physician at the National Institute of Allergy and Infectious Diseases at the National Institutes of Health, who focuses on the diagnosis and management of primary immunodeficiencies. Dr. Freeman received her medical training at Georgetown University Medical School, completed her pediatric residency training at Yale New Haven Children's Hospital, and her pediatric infectious diseases fellowship at Northwestern's program in Chicago. She then joined NIH as an attending physician, briefly focusing on pediatric HIV, and then changing her focus to primary immunodeficiency. Her primary focus is hyper-IgE syndromes, and she has been involved in the initial genetic diagnosis of multiple of these syndromes and is recognized worldwide as an expert in the management of these patients due to her large cohorts of patients followed at NIAID. She also directs the primary immunodeficiency clinics at NIAID, in which she educates the allergy immunology fellows in the diagnosis and management of individuals with complex primary immunodeficiencies. Dr. Freeman has over 200 peer-reviewed journal articles, multiple book chapters and reviews, and has been a speaker in many national and international conferences on the topic of primary immunodeficiencies. Thank you for joining us, Dr. Freeman. Welcome, and you can take it away.
Great. Thank you so much for having me. I'm always happy to speak for the Immune Deficiency Foundation meetings, and looking forward to one day when we're all back in person as well. So today I will be speaking about antibiotics and other antimicrobials, as well as talking about resistance. But I thought I'd start this, the next half hour or so, talking first about the common antimicrobials that we use, just to kind of give our baseline about different antibiotics and antifungals and antivirals that we use in primary immune deficiencies. And then we'll talk a little bit about resistance, focusing on bacteria and fungi. And then we'll talk some about approaches to decreasing antimicrobial resistance. So just to start, it's hard talking about antibiotics in this field or, the types of infections, because there's so much diversity in the pathogens that we see and the germs that we treat. Different types of primary immune deficiencies can have trouble with different types of either bacteria or viruses. And then there's also, so many different types of antibiotics or antimicrobials that we use, and lots of differences in the underlying immune deficiencies that we see. So someone with severe combined immune deficiency will be very different than someone, for instance, with chronic granuloma disease in terms of what they see. So I'm just going to kind of give a general overview first of some of the different infections that we see, as well as antibiotics we use to treat, as well as for prophylaxis. So these are just some of the examples of different types of pathogens or microbes that we see, or germs, in primary immune deficiencies. So you hear about pneumocystis. This is PCP or PJP pneumonia that affects individuals, for instance, with SCID, or there's different molds like Aspergillus or Candida as a yeast. There's different viruses. This is chickenpox viruses, parasites like Cryptosporidia that can cause diarrhea, non-tuberculous mycobacteria, these kind of cousins that are a little bit more wimpy than tuberculosis, strep pneumo that causes things like pneumonia, staph, pseudomonas. So these are all different types of infections that we can see in primary immune deficiency. And then I highlighted some of the different hosts in which we will see these. So some of the primary immune deficiencies they're associated with, for instance, severe combined immune deficiency, can have trouble with pneumocystis pneumonia, as well as some of the other combined immune deficiencies. In chronic granulomatous disease or in hyper-IgE syndrome that I take care of, we can see a lot of molds like Aspergillus. Other immune deficiencies have a lot of trouble with Candida. Some of the severe combined immune deficiencies or other combined immune deficiencies, EPICED, which is gain of function STAT1, hyper-IgE syndrome, viruses we see in different severe combined immune deficiency and combined immune deficiencies, or such as DOC8 deficiency, Cryptosporidia, which can cause bowel and liver disease. We see in TOC8 deficiency and hyper IgMs, the non-tuberculous mycobacteria, and a bunch of kind of more rare immune deficiency, as well as in the lungs when areas and diseases that have bronchiectasis. Strep pneumo, which needs an antibody to fight. So we see that in CVID and XLA and a few others. Staph aureus, and lots of different immune deficiencies, but probably most commonly in chronic granulomatous disease, hyper IgE. And then in Pseudomonas, you can see in mostly in people that have bronchiectasis related to antibody deficiencies. And then I just put up some of the most common antibiotics or antimicrobials like antivirals that we use for treatment. I won't go through all these, but for instance, in pneumocystis, that's where we use trimethoprim sulfa or Bactrim. And molds, we'll use ones like posaconazole, voriconazole, ibuproconazole. Non-tuberculous mycobacteria, you need combination antibiotics. Strep pneumo, ones like amoxicillin or cephalosporins. But the antibiotics we use to treat are sometimes the same as the ones we use for prevention, but sometimes it can differ a little bit. For instance, we'll sometimes use itraconazole, which is an antifungal for prophylaxis for molds. But then if a mold is present, we'll change to a more powerful form like posaconazole. Or maybe the frequency is less. For instance, we'll use trimethoprim sulfamethoxazole to treat pneumocystis pneumonia, but then we use it less frequently, like 3 days a week when we use it for prophylaxis. For Pseudomonas, sometimes you're using antibiotics, but more it's things like airway clearance or inhaled antibiotics. Strep pneumo, for instance, a lot of that can decrease because of immune globulin replacement therapy. So now I'm just going to go through some of the common antibiotics that we prescribe, and just moving my little screen down here a little bit. Some of the common antibiotics we use and some of the issues that we have with them. So, one of the most common antibiotics that are in use is the family of penicillins, such as amoxicillin. This also includes the cephalosporins, ones like cephalexin or cefdinir. And then those can actually have more coverage when they're combined with things that can help with the resistance, such as amoxicillin clavulanate, which is augmentin. So when do we use these and why do we like these? So the penicillins are usually very well tolerated long-term, but there can be issues with these. Some people are allergic and can get a rash. Rash to penicillins is often overdiagnosed, or allergy to penicillin. So some people have had rashes around the time that they got amoxicillin, for instance, but turns out that, it was actually a virus that caused a rash. So this is one of the few antibiotics so you can actually have skin testing to see if there's a true allergy. And some people have GI intolerance from penicillins, but generally these are pretty well tolerated. And they have very good coverage for individuals that have antibody deficiencies because they're very good at treating the types of bacteria that we see there, like strep pneumo or ones like Haemophilus influenza. So these are the type of bacteria that often cause sinus infections. This CAT scan up here is showing sinuses, and this, hopefully you all can see my arrow, but this is a sinusitis. This is pus inside that sinus. And here's a pneumonia. This is a pneumonia that could be from something like Streptococcus pneumonia or Haemophilus influenza. These are very good to treat these type of infections. We also use penicillins like penicillin or amoxicillin often around the time people get dental work if people are worried about infection, because it can treat kind of the bacteria that are inside the mouth. But the downside is that, these are antibiotics where there's increasing resistance because they're used a lot. Amoxicillin and augmentin are used all the time with healthy kids, for instance, with ear infections. And sometimes when kids are, probably just have a viral infection, they are given these, and that contributes to the resistance. And some people are allergic to these. Oops, it went the wrong way. Hold on. Okay. Now we'll move on and talk about trimethoprim sulfamethoxazole. This is Bactrim. So why do we like this antibiotic? It's extraordinarily well tolerated long-term. We have very long track records of people on this for prophylaxis, either daily or twice a day in chronic granulomatous disease or hyper IgE syndrome, or 3 times a week, for instance, for prophylaxis for pneumocystis. And people are on this often for decades and decades and, really don't have toxicity from it. And if you become resistant to Bactrim, for instance, if you have a staph infection that's resistant to this, it doesn't then cross-react. If you can become resistant to this one, it doesn't mean that you're resistant, for instance, to a cephalosporin like cefdinir. And then it has kind of a broad spectrum. So these trimethoprim sulfa works extraordinarily well against pneumocystis and also against staph, including some MRSA, as well as nocardia. So here is a CAT scan of the lungs. This is nocardia pneumonia. That's a funny bacteria. So that's in chronic granulomatous disease. And then here's a picture of pneumocystis, kind of this diffuse pattern in the lungs. These are the lungs, and this kind of white patchiness is the infection that we see here. And then on the bottom is a picture of a CAT scan of a staph pneumonia and hyper IgE syndrome. And this over here is normal lung, and over here is this big pneumonia. So Bactrim could have prevented that pneumonia there. So the downsides of trimethoprim sulfa is that, you know, some people are allergic. Sometimes we'll even think about desensitizing people if they're allergic to this, because it's so good for prophylaxis in some of these diseases, like in chronic granulomatous disease or in prophylaxis against pneumocystis. If it's used at kind of higher doses, it can cause bone marrow suppression. That means that it can make your blood counts go lower, like your neutrophil count or your hemoglobin or platelets. But when people are on it for prophylaxis, that's uncommon. And then very rarely it can cause other issues like kidney or liver issue, but that's not common. Okay, another one that we like to use sometimes is azithromycin. This is also called Zithromax or Z-Pax. So we like this because it's usually very well tolerated and it can be dosed daily. Or sometimes for kind of more of a prophylaxis, it's used 3 days a week. That's what they do in the cystic fibrosis community for individuals with bronchiectasis. And this is good for some sinopulmonary infections as well as environmental mycobacteria that can be a problem when you have bronchiectasis. So the environmental mycobacteria, these kind of weaker cousins of tuberculosis that can cause problems in people with either bronchiectasis or people that are immune compromised. It also has some anti-inflammatory properties, you know, and that seems to help for people with bronchiectasis in terms of exacerbations. So here's a chest CT. Again, over here is kind of what normal lung looks like. And over here, some of these dilated kind of airways with kind of these circles around it. This is bronchiectasis. So it can decrease some of the exacerbations that we see in bronchiectasis. The downside, some people have some intolerance to azithromycin. It's pretty easy for bacteria like strep pneumo or staph to get resistant to it. And then it can rarely be associated with arrhythmias. This is extraordinarily rare, but if you're combining lots of antibiotics that can have similar effect on the heart rhythm, then it's important to check an EKG to make sure that it's not causing any issues. Okay, moving along to fluoroquinolones. This is the class of antibiotic that has levofloxacin, ciprofloxacin. We like these because this is the only oral antibiotic that treats Pseudomonas, which is a common bacteria that we can see in people with bronchiectasis. So bronchiectasis can complicate lots of immune deficiencies like CVID or XLA. And it has a great spectrum for pneumonia. Pretty much all the strep pneumos out there almost always are sensitive to this or other types of bacteria that cause like regular pneumonias that you get out in the community. But these do have downsides. Pseudomonas easily gets resistant to these. When you're on these medications, people can develop joint pains and it can be associated with tendon rupture. This is more likely if people are on this with other medications like steroids. There can be some vascular side effects or again, like azithromycin, if you're on multiple of these, it can affect these heart rhythms. And so it's a good idea to check the EKG. You know, we don't worry if people are just on these for a few days, but if you're combining them with other drugs long-term, it's important. And some people do get diarrhea or other problems from it. You know, these are antibiotics that could potentially set people up for things like C. diff. Okay, so now we'll talk a little bit about antifungals. So, you know, when we talk about antifungals, there's two kind of fungi that we worry about in the world of primary immune deficiency. One is yeast, or three kind of groups actually. Yeast, so yeast are like Candida. I have a picture here of thrush inside someone's mouth, Candida, as well as fingernails with Candida. And then there's molds. This is things like Aspergillus that can cause infections in people with chronic granulomatous disease or people with hyper IgE syndrome. Here's a chest CT with a cavity with some Aspergillus, some mold inside it. And then there's also kind of some fungi that live in the environment, like coccidioides, which is common in the southwest of the United States, histoplasma, which is more kind of in the Midwest as well as the East Coast, cryptococcus that can be in different areas, sometimes associated with bird droppings. But those are environmental fungi that can cause problems in some primary immune deficiencies. So there's different antifungals that we use, but compared to antibiotics, there's a lot less spectrum of antifungals. So most of them end in azole. So we call them the azoles. So kind of the most simple is fluconazole, and that covers yeast like Candida or that coccidioides I talked about in the Southwest or Cryptococcus, but it doesn't cover molds, but it's extraordinarily well tolerated, fluconazole. Itraconazole covers those yeast, plus it gives some prophylaxis against molds. And this was actually studied for chronic granulomatous disease for prophylaxis and showed that it had great benefit. But, these do have downsides. And it can cause some trouble, for instance, of the liver, but not very frequently. For itraconazole, it has some quirks to it. The liquid is better absorbed than pills and needs more of an acidic environment for absorption, like taking it with orange juice, for instance. And it can interact with some medicines, including with steroids, such as prednisone. Voriconazole then is much better for molds as well as for yeast. So voriconazole is used for treatment of things like aspergillus and other molds. But, it also has some downsides. Any of these can cause liver toxicity, but you can see that with voriconazole. One of its special ones, though, is it can cause photosensitivity. These are antifungals that were initially studied more in people in the hospital, for instance, people getting bone marrow transplants, and not people with primary immune deficiencies who might be on these medications, but living their lives and outside. So it can cause skin sunburn, and long-term, it can actually lead to things like skin cancer. And long-term, it can have other issues too. Posaconazole is kind of a cousin of voriconazole, also covers yeast, also covers molds like aspergillus, also can have liver toxicity. It can also interact sometimes with other medications, but we don't see that photosensitivity. And isobuconazole is also very similar to that. Amphotericin is a great antifungal. It pretty much covers everything, but it's only available IV, and that can have a lot of toxicity, such as in the kidneys. Pharmacies can sometimes make a suspension, though, for swish and swallow with that. And then echinocandins are also only available IV, and they're mostly very good for yeast, like Candida. Some examples are micafungin, caspofungin, nidulafungin, but right now, those are only available IV. We'll talk just kind of briefly about antivirals. Antivirals are even more limited in our choices, and most viruses out there aren't good antivirals. For instance, one virus that can cause lots of trouble for certain people with primary immune deficiency is norovirus that causes stomach flu, but norovirus sometimes can lead to kind of a chronic infection of the intestines, and we really just don't have antivirals for that. The ones that we do have antivirals for are those of the herpes family. So herpes or chickenpox or shingles. And that's acyclovir and valacyclovir. Those are the two most common ones. Those are cousins of each other. And here's a picture of an individual with hyper IgE syndrome with shingles. You can see the rash of shingles. And for that, you can get something like valacyclovir or acyclovir. It's good for prevention or it's good for treatment. And these are used a lot in T-cell immune deficiencies, like SCID or combined immune deficiencies or GATA2 deficiency. And, these are extraordinarily well tolerated over time, and resistance is really uncommon. Ganciclovir and foscarnet are two other antivirals. These both have activity against the ones I mentioned before, like herpes and chickenpox, but also have activity against CMV. CMV is a virus that can cause trouble for some different primary immune deficiencies and also in the bone marrow transplant setting. So they have different toxicities. Foscarnet's only available IV and is hard in the kidneys. Ganciclovir has valganciclovir, which is oral, but can cause bone marrow suppression. So it can make your blood counts go down over time. And then there's antivirals that are available for the flu. Oseltamivir, that's Tamiflu for influenza treatment or after exposure, for prophylaxis. Baloxavir, that's Zoflus. This is not Zofluza, I think I forgot an A. This one hasn't been studied in immune-compromised individuals. We haven't used it as much, but those are important in terms of influenza. There are some others out there too. And then recently, with COVID-19, we have some options. Nirmatrelvir, ritonavir, that's Paxlovid, which works very, very well. It can have drug interactions though, so you really need to talk to people about that, but started early in the course of COVID, or remdesivir, which is only available IV for COVID-19. Okay, so let's talk a little bit now about antibiotic resistance, which is something that, drives us all crazy and that we worry about. So I'm not going to go into details about this, but there's, bacteria are smart. When they see these antibiotics out there, they figure out ways to try to get around these antibiotics. And the more exposure you have antibiotics, the more time these bacteria have to try to figure this out. And the other thing that bacteria can do that's kind of smart is they can sometimes share this resistance. So sometimes bacteria will have, you know, a little, these kind of little bits of DNA in the bacteria called plasmids, and they can then send those over to other bacteria and kind of share those plasmids to cause resistance. And there's all different ways they cause resistance. So sometimes they can make these pumps, these efflux pumps, or they're actually, this is a cell. So they're actually then, this is the bacteria, pumping different antibiotics. So like fluoroquinolones, they can do this. That's like ciprofloxacin or levofloxacin, where they're actually pumping the antibiotic out of the bacteria so that it can't affect them. They can also block the penetration, so they can interfere with like how the antibiotic is interfering with the cell wall, for instance, of the bacteria. They can do that with things like beta-lactams. Those are ones like penicillins and cephalosporins. They can affect kind of some of the enzymes on the inside. So they can affect kind of how the bacteria is making proteins, or how it's kind of, how the bacteria, the antibiotic then affects the bacteria on the inside. And here are some of the examples of that, which include some of these ones I said before, macrolides, or for instance, azithromycin. The bacteria can also, use different proteins as making to inactivate the bacteria. So you hear about these with like things like ESBLs. Those are the beta lactamases, or the carbapenemase resistant, like E. coli's, for instance, in which the bacteria actually come up with ways to inactivate the enzymes in the antibiotics. So we've seen a lot more bacteria and fungal resistance over the years. So this is a graph looking back since 1980 until not quite the present. But, for instance, here is MRSA. So MRSA used to be really uncommon. So that's methicillin-resistant Staph aureus. So, but the more and more antibiotics that were being used, we started seeing this more. And then back here, kind of around this big peak that happened in the late 90s and early 2000s, that's because, MRSA used to just be something you saw in the hospitals, but suddenly we started seeing it in the communities. So people were getting skin infections from MRSA in the communities. And part of the issue with MRSA is that so many people, like 20% of people, carry Staph aureus in their noses all the time. And then if you're being exposed to antibiotics, for instance, cefalexin, that's Keflex, or amoxicillin clavulanate, which is Augmentin, you're taking that antibiotic maybe because you have a sinus infection, or you have an ear infection with strep pneumo or Haemophilus or something like that. But the MRSA is the staph that's hanging on your nose is being exposed to it too. So it starts getting smart and figuring out ways around this and becomes MRSA. So, which is the methicillin resistance. We've also seen over the years this increase in other resistant bacteria. So this is vancomycin resistant enterococci. This is mostly, you see this in the hospital, but then it affects, the antibiotics that you can use. And then this is showing an increase in fluoroquinolone resistant Pseudomonas. So that's, Pseudomonas that's resistant against those oral agents like ciprofloxacin and levofloxacin. So, there's tons more like E. coli's and Klebsiellas that are becoming resistant. But, it's just like a lot of them are kind of following this graph, where we'll see, some increases for a while and then it settles out some. And the hospitals are doing a ton to try to prevent the spread in hospitals. But, it used to be that we were just seeing this in bacteria, but now also in other organisms like fungi, we can see some resistance. One that has gotten a lot of kind of press in the last few years is Candida auris. That's a yeast. But, yeast, usually we all have yeast inside our bodies. And you don't think of spreading it from person to person, but Candida auris is actually spread through hospitals where, it is spread from person to person in a hospital. And it's resistant to those azoles like fluconazole that I was mentioning. And this has been increasing over recent years. Again, this is mostly being seen in the hospital setting, but hospitals are now beginning to screen patients for this and identify it to make sure that there is contact isolation to prevent the spread. So what can we do and what have people done to fight antibiotic resistance? So one thing that has really helped for strep pneumo resistance is vaccination. So, over the last couple decades, we started giving, babies the Prevnar vaccines. And now it keeps getting more and more, right? So now we're up to the Prevnar 20. And with more and more vaccine against strep pneumo, then less people actually carry strep pneumo in their nose and throat, and then can develop those resistance when they're getting things like antibiotics. So you can see when some of these vaccines were introduced, and then you see a nice kind of drop off over the next few years of how much resistance is seen. So the purple here is any antibiotic, then this is against penicillin. You can see the penicillin resistance has really gone down and erythromycin has stayed really high. But it's really, you've seen kind of these responses with the penicillin. And then it's really important to, only get antibiotics when you need them, which is harder in people with primary immune deficiency. But, this is where we hope that, the general pediatricians out there and the family practice doctors and the internists, that people are really thinking about it and not giving an antibiotic if someone's coming in with a cold. So if it's a viral infection, there's no reason to be on an antibiotic. And I think what's hard sometimes in primary immune deficiency is it can be a lot harder to tell, is this a virus or is this a bacterial infection? So we use antibiotics a little bit more, but, for the general community out there, I think, there's a little bit of looseness with antibiotics when there doesn't need to be, and people need to be more careful because otherwise it's contributing to this increase in resistance. And then finally, it's really important to get culture data. For instance, if someone has a pneumonia and, initially you can start, a broad antibiotic, but, getting that culture data to say, okay, in a couple days, because you got a sputum culture, you'll then know in a few days, okay, what was causing the pneumonia? For instance, maybe it was staph or maybe it was strep pneumo, and then which antibiotic is best to target that. So you'll know, okay, for that one, maybe it was MRSA. So maybe now you'll use linezolid, which works really well for MRSA pneumonia, or, it was strep pneumo. And so, but luckily it was penicillin sensitive. So then you can narrow down your antibiotics to something really specific for it. And then, it's getting so much easier to check for viruses. There's all these panels now where you can check and see, is this RSV? Is this parainfluenza? Is this COVID? Is this influenza, the flu? Because if it's pretty clear it's a viral infection, then often you can hold off on antibiotics as well. The other thing in the primary immune deficiency world is, although we use a lot of antibiotic prophylaxis, we also sometimes, think about targeting the specific immune defect to avoid sometimes as much prophylaxis. For instance, in CVID or in XLA, right? If you're having recurrent pneumonias, sometimes the immunologist will push the dose of the IVIG or the subcutaneous IgG so that you have a little bit higher trough. Because with a little bit higher trough, sometimes there's a little bit less of the breakthrough infections. And then I put here some examples of specific immune deficiencies where, recently we have much more targeted therapy to try to decrease infections. For instance, in STAT1 gain of function, which is one of the immune deficiencies that's associated with having a lot of trouble with Candida, but other infections as well, those individuals can also have autoimmunity. So we started using JAK inhibitors, for instance, ruxolitinib or baricitinib, to target that STAT1 gain of function disease, targeting more the autoimmunity. But we noticed, oh, look, it actually makes the mucocutaneous candidiasis get better. So if you can actually correct the immune defect, then you might need less of the antibiotics or the antifungals in this case. Another example of that is on in hyper IgE syndrome. In this paper is from STAT3 mutations. In recent years, people have been using dupilumab much more. That is a monoclonal antibody against IL-4 and IL-13 that treats eczema. And with a lot less eczema, we're seeing a lot less staph infections. So you can see some of the pictures here from this publication. This is before and then after dupilumab, showing that kind of improvement in the skin. And if you're the improvement in the skin, less staph infections, less antibiotics, less bacteria that's there to actually get resistant. And of course, then there's also bone marrow transplant to correct the immune system, which is kind of a, the biggest scale right out there to minimize then the infections. Now, I don't want people to even be too nervous about all the resistance, because, we're also coming up with more and more antibiotics and antifungals to try to treat these resistant bacteria and fungi. But, you try to keep those in reserve and only use them when you need them. But, for instance, for MRSA, for a long time, we just had IV vancomycin or other IV therapies. But, now over the last 10 years or so, we have oral medicines that can treat MRSA, like tadalafil and linezolid, and of course, Bactrim or clindamycin as well, if they're sensitive. But these are kind of some of the newer ones that treat all of them so far. There's a bunch more IV antibiotics that have been available in recent years to treat kind of resistant gram-negative bacteria. I listed a couple ideas there. Now, the Candida, the yeast and the fungi is hard. So, because there haven't been that many options, but there are some coming out. It's just that right now, most of these are investigational, but there's one been studied for azole-resistant Candida, Ibrexafungerp. There is this one where there was actually a recent report in an individual with stop-1 gain-of-function, which is a weekly medicine called Razafungin. There's ongoing studies on for some resistant molds. We're involved in a study here about Lorafilm, which can treat some of the resistant Aspergillus. And there's a few others that are coming out as well that have novel kind of ways to treat these and should be more helpful for resistance. But, preventing infections isn't just about prophylactic antibiotics. So it can also help to prevent some of the resistance if we think about ways to prevent infections that don't always require antibiotics. For instance, antiseptics, for instance, in hyper IgE syndrome, where the individuals have a lot of trouble with eczema, and the eczema has a lot of trouble then with staph infections. We know if we can decrease the amount of staph on the skin, their eczema actually gets better. And you can do that through things like dilute bleach baths or antiseptics like chlorhexidine, or even swimming in chlorinated pools, that can really, decrease how much staph is on the skin. Then there's a lot less staph there to cause resistance. I already talked about optimizing immune globulin replacement doses to try to help with some of the recurrent pneumonias. Airway clearance for people with bronchiectasis is a really, really good way to decrease the amount of episodes that people have things like Pseudomonas flares. That's either through hypertonic saline nebs or using devices like the aerobicas or acapellas or pulmonary rehab or using vests. Then there's just things that, depending on your immune deficiency, it's good to avoid. For instance, for individuals with chronic granulomatous disease, you want to avoid big mold exposures. So, things like mulching or hay rides. And here's a chest x-ray of someone that was mulching, and, all these kind of white spots through the lungs were from all the inflammation from being exposed to the mold. And then, another important thing with preventing infection is that, there are, as I talked about earlier, certain fungi that have higher risk areas of the country or activities with that. For instance, the coccidioides is a fungus that causes valley fever in the United States Southwest. But, certain immune deficiencies can have trouble with that too. So, thinking about where, for instance, you're traveling to try to minimize infections. Clean water supply is really important for preventing Cryptosporidium, which can cause both GI disease, but also liver disease for certain combined immune deficiencies. And of course, washing hands. The more we can wash hands and using masks in high-risk environments to not get as many kind of exposures to things to try to prevent either primary or secondary bacterial infections as well. And finally, vaccines, so household contacts should be up to date to protect, those with immune deficiencies who don't respond as well to vaccines. So for instance, flu shots are important for everybody with primary immune deficiency, but it's also important to make sure that the household contacts get those vaccines to prevent then the flu from being in the household as much for contact. And that's true for the COVID vaccines as well. And this was some of our data, just to add some spice to the slide, showing the responses for our patients with primary immune deficiencies to the COVID vaccines. As a healthcare worker, showing normal responses. But, in the individuals that we are seeing, most of them we're seeing some good responses after the second dose. Of course, for certain people with antibody deficiencies, we might not see that, and they will have to get that response through the immune globulin, but you can see a T cell response too, which can be helpful. And with that, I'm happy to answer any questions. And there's a picture of NIH.
All right. Thank you so much, Dr. Freeman, for providing that overview of antibiotic use and antimicrobial resistance. We now have some time available for Q&A but before we begin, please remember that everyone's treatment and condition is unique. The information presented during the session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. So with that, we received a lot of great questions, and we're going to do our best to get through as many of them as we can. So we're going to start with the first one, and it is, what is your opinion on fecal microbiota transplant as a treatment when the antibiotic is not working during infection?
Okay, so I assume, I don't know if they mean for C. diff or for other purposes. So fecal transplants have gained in popularity in the last bunch of years, initially for C. diff. So, and I think they work really well. You have to be a little careful, and people that have immune deficiencies, things should be used a little bit more cautiously. So this is one of those examples where you'd have to talk to your team and see what is appropriate. But, for the general population, I think fecal transplant is a very good option when there's recurrent C. diff or when the C. diff is not responding to the initial therapies. Fecal transplant is now being looked into for some other conditions, like some inflammatory bowel type conditions that can be associated with primary immune deficiencies. There's a study, going on for that with chronic granulomatous disease. I think we just don't know yet. These things are being studied right now, but I think kind of normalizing the microbiome could have some good effects. Great question.
The next question is, I have been having regular life-threatening resistant infections since 2 months, in parentheses, lots of strep, but ranging into really bizarre infections. I have become anaphylactically allergic to all but 3 classes of antibiotics, among others. Do you see this often?
Okay, so this person is having more resistant infections and then having anaphylaxis. So that's a severe allergic reaction to the antibiotic. So it's limiting the choices. And so, I think this is a good time also to have an allergist be involved and see, what exactly is this, person reacting to, which classes of drugs are important. And then looking more closely at, what is actually leading to these severe infections. So we do see that sometimes, different, everyone with primary immune deficiency has immune dysregulation, and some types of immune dysregulation can cause more reactions, and people with primary immune deficiencies are exposed to more antibiotics. Sometimes we'll see more allergic reactions, and it can make it really tricky. So it's important to kind of work with an allergist as well as, to try to figure out kind of what are some choices that are out there, but also really getting to the bottom of, why suddenly in the last couple months some severe infections. So I'd recommend, like, for instance, talking to an infectious disease doctor, but I'm biased because I'm infectious diseases.
That is really great advice. The next question, with primary immunodeficiency, aren't we all inevitably going to get some sort of resistant, especially as we age and get more infections?
Yeah, that's a good question. It's surprising sometimes we see antibiotics, though, last for decades, and although people probably have some resistance there, sometimes we don't see there being that many issues. And I think in part, this depends a little bit about what type of primary immune deficiency this is. For instance, in chronic granulomatous disease, a lot of the infections are coming from the environment. So, they're getting, some of the like Burkholderia that's in for instance, from a water source, or Cardia that's in the soil, or the mold that's in the mulch. So, and those bacteria or fungi that are in the environment are way less likely to be resistant. They're not being influenced by taking Bactrim for the last 30 years and taking itraconazole. So that's why I think, sometimes we see decades and decades of these antimicrobials work. And then I think that's when kind of the flip side of that is the people with, for instance, with hyper IgE syndrome who have eczema and, are chronically colonized with staph. And that's when we have to use something in combination with the antibiotics to really kind of decrease the chance of resistance, like dilute bleach baths or chlorhexidine or whatever. So, I do think being on antibiotics for a long term can cause resistance, but, there's a way to kind of do this to try to minimize the impact from it. Also, we try with the prophylaxis to be as narrow as we can. For instance, when you're on Bactrim for prophylaxis, it doesn't wipe out a lot of the good bacteria in your intestines compared to some of the stronger antibiotics that would do that.
Next question. How can a patient tell if a bacteria is resistant to antibiotics? If the same infection reoccurs a few days after a round of antibiotics, is this a sign of resistance?
Yeah, so not always is that a sign. So the way we tell resistance is the microbiology lab, when they grow the bacteria, they then test the bacteria against a range of antibiotics. So based on the type of bacteria, they'll test it against, this selection of, I don't know, sometimes just a few antibiotics and sometimes a whole panel of like 6 or 8 or whatever antibiotics. So that's how we tell. Now, sometimes, for instance, in bronchiectasis, you can be chronically colonized with a bacteria. So it can be really hard to make your culture totally go to negative. And the antibiotic can still be working and it's not resistance. It's just really hard to get to a negative culture. So that it's a little hard to know from that question, but yeah, but sometimes, or it could be that there's some sort of breakthrough. But it's important for those to be in touch with people to figure out, to make sure that you have that culture data and that they're checking it to see which antibiotic is best and what it's resistant to.
Next question is, should people with PI who are having surgery or invasive dental work, such as wisdom teeth extraction, take antibiotics pre and post surgery as a preventative, or wait and see if infection sets in before taking antibiotics?
Okay, that's a great question. I think in part, these are all great questions. It's funny because I'm part of a group we're trying to write the guidelines for some of the antibiotic resistance for the American Academy of Allergy and Immunology. And, it's something we're debating, is putting in how strong should our recommendation be for dental prophylaxis or surgical prophylaxis, because that hasn't been included in the past. So, and I really think it depends on the type of primary immune deficiency. So there are some primary immune deficiencies where the types of bacteria in the mouth or, or on the skin can cause a lot more problems. So, I do focus on hyper IgE syndrome, so I think a lot about that disease. But in that disease, we do see a lot of dental infections, and I do and we see a lot of skin infections, and surgical site is breaking the skin. So I do give my patients prophylaxis starting before really invasive dental work or surgeries, like significant surgeries. Now, I'm not saying though that every other immune deficiency needs that, because some immune deficiencies don't have that much trouble with staph infections. They might be having more trouble with viruses or fungi, and and I don't always then think about giving the prophylaxis. So I think it depends on what type of immune deficiency, and I think it's something that's not standard across each center.
Okay. Next question is, I have had C. diff from antibiotics and I can't take certain antibiotics due to mast cell disorder and a connective tissue disorder. I'm afraid I'll get an infection and not be able to treat it. What are your suggestions?
So I think there, that's when it's kind of important about meeting with an allergist to come up with a plan in terms of which antibiotics are best in terms of tolerance, but also less likely to cause C. diff. Based on how often and how big a problem there has been with C. diff, sometimes we'll actually give medicine for C. diff when we start an antibiotic. So that's an approach we've used at times if C. diff has been a big problem.
Next question. Should a bronchitis patient be on an antifungal if their sputum culture shows Candida Guillermondi?
Or Glabrana, maybe.
Yeah.
So the question is, someone with bronchiectasis, if the sputum is showing Candida, one of the Candida species, should they be in an antifungal? So I usually not. So Candida when in sputum, Candida grows frequently, but it's because of the mouth. So Candida is extraordinarily rare to actually cause pneumonia. So you see it in cultures, but most of us think it's not actually causing, real lung disease. The times I've used antifungals in people with bronchiectasis is if I think there's really mold contributing to the chronic infection in the bronchiectasis. So I do more for mold, and I almost never have for Candida there. But again, these are all things you have to talk about with your own provider too.
Next question is, may the conservative treatment with extensive use of antibiotics in the infancy period cause complications in older ages?
I think that's, these are these microbiome questions that people are trying to answer, right? And I think this is why I think a lot of us are trying to keep our antibiotics super narrow. So, we don't have the answers to a lot of these things. I don't think it's going to be major complications or, significant issues, but there might be subtle things that are affected by the microbiome. People have done studies looking, for instance, at obesity levels or, the risk of diabetes or whatever. But, it's, and I think this is a reason why, we try to keep things narrow and we try to give antibiotics just when they're needed. But, there is definitely a role for prophylaxis, right? I mean, we will give an infant, we will make sure an infant with SCID, for instance, is on antibiotics all the time, because otherwise the mortality risk is really high. So, we have to balance those risks.
All right, next question. Are repeated rashes on antibiotics a sign of resistance?
No, it would not be a sign of resistance. Whether or not there is, well, I don't know, actually. I'm not sure what they mean by the repeated rashes. So, do you mean like a rash with an allergic reaction, or is this a rash like a skin infection rash? So if it's a kind of like a reaction to the antibiotic, that would not be a sign of resistance. It might be a sign of intolerance or an allergic reaction to the antibiotic. If it's the infection coming back, then it's possible. For instance, if my patients are having a lot of staph infections and eczema breakouts, despite being on staph prophylaxis, I will often get a culture, for instance, of the nose where people cover, or colonizer staph to see what the resistance pattern is like. So, not sure, but yeah.
The next question. There seems to be a lot of conflicting data on probiotic use. Can you speak to their efficacy as related to patients with PI who are prescribed many courses of antibiotics in a given year that tend to disrupt the GI microbiome?
Yeah. So, I think probiotics, I think there are a lot of opinions out there, and there's a lot of different probiotics out there. And a lot of people with primary immune deficiency do totally fine without being on probiotics. And there's certain types of primary immune deficiency where, there's really severe immune deficiency, or people have central lines where you don't want someone on a lot of probiotics because they can actually cause sometimes like central line infections and stuff. So there definitely can be downsides of probiotics. So I think, in part you need to talk to your provider about, is a probiotic okay or not? I have some patients, I would say probably most of my patients don't take them, but I do have some patients that do feel like it helps them. And it's patients where I don't think it's a risk to them. So, it's really on an individual basis, I think.
So we still have a bunch more questions. So we're going to continue chugging along with our last 5 minutes to answer as many as we can. The next question is, it's still good advice that on the East Coast of the US, doxycycline is a good antibiotic because it remains effective against staph?
Yeah. I don't think that's just the East Coast. I think the West Coast too, but most staph is still sensitive to doxycycline. I try not to use it as prophylaxis unless I need to, but it can be used pretty commonly for treatment. I wouldn't use it for really severe infection, but for like a skin infection, I do use it sometimes. Yeah. It's usually sensitive still. If it's not hospital acquired, if it's community acquired MRSA staph. Doxycycline is one that can cause some photosensitivity, so you have to be careful about sunburn.
Should a patient with bronchitis have a routine spectrum culture to know what is going on, or only if there's a problem?
Now, I like to do that. I also, I also work at NIH, right? So you have to take everything I say with a little bbit of grain of salt, that I can get cultures and not have to worry about insurance companies or who's going to pay for them, because, you know, we could do that stuff for free. But I find it extremely helpful to get routine sputum cultures every once in a while and people with bronchiectasis, because I can then know what they're colonized with. For instance, if they're colonized with Pseudomonas and then they have an exacerbation, there's a good chance it's from the Pseudomonas. And then I already have recent antibiotic data and I can choose the antibiotic. So that's why I do it. The other thing is to look for things like non-tuberculous mycobacteria that can be a problem in bronchiectasis, or molds or whatever. So I like having that data available. It's not that I'm going to treat whatever the person grows immediately, but it's so next time that person gets sick, I have some idea what they're colonized with, and it helps me choose an antibiotic.
Next question, as a PI CVID patient, I am on doxycycline daily. Is my resistance worsened when I get sick and given another antibiotic to take in combination to treat infections?
Okay, so doxycycline, it's kind of like it's built differently than Bactrim. So doxycycline and Bactrim don't have any resistance with each other, but it's kind of like what I said about Bactrim earlier, in that if you're resistant to doxycycline, it doesn't make you resistant to, for instance, augmentin or the cephalosporins like ceftonir or something like that. So if you're on doxycycline and you get a breakthrough infection, there's still tons of different antibiotics you can use to treat that, or there's different antibiotics you can use to treat that infection. So it's not going to cause a lot of resistance to others, which is the reason why I sometimes use it too for prophylaxis.
Okay. Try to squeeze in one more question.
Okay.
How do you feel about doctors providing patients with antibiotics, antivirals, and antifungals as prophylaxis? My doctor knows I will not take them without talking with them, but it is personally easier for me to have these meds before getting sick.
Yeah, no, I mean, I think there's definitely a time and place for that. You know, I mean, I think a lot of people with primary immune deficiency get to know their bodies. And for instance, you know, if you don't have a spleen and you have a fever and you need to take an antibiotic, it's nice to have some on hand. You know, if you're not right next to a doctor's office or right next to an urgent care, if you're traveling or something like that. So I don't think it's a wrong thing to do. And I mean, I've done that with my patients, some of them, you know, I think it depends on the patient, the provider there, but I definitely, you know, it is something that can be considered if situation lines up correctly. You know, if it's someone that's had repeated the same type of infections, for instance.
All right, thank you. So with that, our time has come to an end. I know that there were a lot of questions that we did not get to during today's section in our Q&A. So if you still have questions and you didn't get them answered, we recommend that you go to IDF's website and submit your questions through Ask IDF. And IDF will be in contact with Dr. Freeman, making sure we get your questions thoroughly answered. And so you can have those answers moving forward. So thank you so very much, Dr. Freeman. It has been an honor to have you join us today. This session is one of just 39 unique learning opportunities provided through our 2023 PI conference. We hope you continue tuning in today as we explore other critical topics for the PI community. Have a great day.
Bye. Thank you. Okay. Now I can go. Thanks.